I'll turn it over to you, Dr. Norby, and thanks for being with us.
Yeah, of course. Thanks for that introduction. Really nice to have you all here. Thank you for taking the time this afternoon to hear me talk. Hopefully it's not too boring. All right, so let me just pull up my presentation here. All right, are you all able to see that?
Yes.
Okay. So like she said, my name is Ray Norby. I'm a 5th year radiology resident here at UVA. I've been here since medical school, and I used to volunteer at the center in the past with Berta. So my specialty is interventional radiology. It's a field that isn't even super well known within the medical community. And I feel like the general public doesn't know much about it. So but it's a really exciting and really innovative field. So I think it would be cool to learn about. So hopefully you guys will take something away from this. So to start with, there was actually this kind of docu-series made called Without a Scalpel, highlighting interventional radiology, which came out a few years ago. So let me see if I can pull that up for you guys. Hold on. I need to share a different screen. I'm just going to play the first couple minutes of this trailer. All right. Are you all able to see this?
Yes. There's no sound though. Is there supposed to be sound?
There's supposed to be. Oh shoot.
I think you have to go out, and then there's a blue button on the bottom when you hit share screen, says
Okay.
make sure you have sound or something.
Gotcha. Sorry about the technical difficulties. Oh, there it is. Okay.
Yep.
Thank you for that.
You're welcome.
All right. Not used to presenting on Zoom. Can you hear sound now?
Absolutely.
Awesome.
You could actually treat disease from the inside out rather than the outside in.
Interventional radiology was born from innovation.
And you have one of those aha moments. It changed the whole way we started to think about this.
There's no limit to what we can do.
We feel a little bit like the masters of small things, doing major surgical things through tiny holes.
This is the future.
When I have patients, they say they're ready for their surgery, and I tell them, you're not going to have surgery today, you're going to have a procedure. We don't cut people open. We make a tiny pinhole. We use the body's natural pathways, the artery, the vein. We can thread our tools, our catheters, to the area that's diseased.
Charles' daughter, who was at the University of Oregon, had that moment, that light bulb moment where he went, you know, we can actually fix something rather than just take pictures. He realized you could actually do something once you get in there. He was very intense, and once he believed in an idea, he believed in it.
It's just a huge legacy that has spilled into so many other procedures and specialties.
All right. Let me get back to my presentation. So that was just a little teaser. Give me 1 second. All right. So interventional radiology, it's a relatively young specialty. It's probably the newest specialty kind of within medicine. And it all began kind of in the 50s and 60s. Previous to that, there wasn't really any safe way to kind of access things in the body in a minimally invasive way. So the only way to get in was through surgery, which at the time, required a large incision. If you wanted to go in someone's belly, you had to make a huge incision so you can see everything. But that all changed in 1953 with this physician scientist, Sven Seldinger. So he was a Swedish physician, and he had this technique for accessing blood vessels or other hollow structures. So there's a picture of it here, but basically you use a needle to access the blood vessel. You put a wire through the hollow needle. So then you have a wire in the blood vessel and you take the needle out. And then you can put a catheter, which is a thin tube, over the wire and into the blood vessel. Then you take the wire out, and then you have access to that blood vessel with the catheter. And you can put other things through there. You can put contrast dye through there and take pictures. So angiograms that's a fancy word for a picture of blood vessels using contrast dye and x-rays. And so before this, they had done angiograms, but they required surgical cut downs, actually visualizing the blood vessel with the naked eye. But after this, you were able to use needles and go through the skin and do it all through a tiny hole. Now, Charles Dotter is considered the father of interventional radiology. As a person mentioned in the video, he was apparently a genius and had tons of ideas. He predicted a lot of the major medical advances in the field and helped create a lot of them, but he was also very abrasive and short-tempered. He helped create rapid X-ray tubes, which allowed you to do kind of live X-ray images, which made our field possible. He created a gentle J-tip guide wire to prevent causing trauma to the blood vessels when you put a wire in. And he was the first to do angioplasty. Now, Andreas Grunzig was a German physician, and he created the first balloon catheter. So, like I said, with the Seldinger technique, you can get a blood vessel or a catheter into the blood vessel. He created a special catheter that had a balloon attached to it, and then you could inflate the balloon and expand it inside the blood vessel and therefore dilate an artery. So if there was a blockage or narrowing of the artery, then you could use this balloon to stretch that narrowing open and help improve blood flow. And so he first described this being done in coronary arteries for patients with coronary artery disease, which causes heart attacks in the 70s. Now, these techniques really kind of revolutionized medicine because it meant you could treat things from inside using minimally invasive techniques rather than having to do a surgical bypass, cutting someone's chest open to see their heart and replacing the blood vessel with a graft. And now, because of this, many things can be treated non-surgically. And the great thing about interventional radiology procedures is that in general, they're much lower risk than their open surgical counterparts. It results in shorter hospital stays and also a quicker recovery and safer recovery from the procedure itself compared to an open surgery. So here's just a little diagram describing that technique. So this could be any artery in the body. Here they're saying it's a coronary artery, which is an artery leading to the heart. But as we get older, we develop plaque, which narrows these arteries, and that reduces blood flow. And eventually, if there's not enough blood flow, then the heart gets damaged or whatever this artery is leading to lacks oxygen and gets damaged. And that can cause problems. So using the Seldinger technique, you get a wire, then a catheter down to the blockage, and then you can inflate that balloon, push that plaque to the side, and open up the blood vessel and see have greatly increased blood flow and treat things that way. Stents were the next thing that were developed in the late 60s and then throughout the 80s. You can see in this bottom left image, here's a blood vessel. You can see a blockage in the middle there. And then after the balloon. A balloon is inflated, opens that up, and then they left the stent behind there to help keep it open. And here are some other stents that are used in the biliary system, but they're used all over the body now. And not just by interventional radiology, but GI specialists will place stents in other places. So it's widely used. This is a diagram showing how the stent's placed. It's very similar to the balloon, except instead of just inflating a balloon, you're inflating a balloon with a stent over it and then leaving that stent as a scaffold to help prevent it from collapsing down again. So it can lead to improved patency and more durable results. So interventional radiology is an extremely broad field. We can do a lot of things using these minimally invasive techniques with image guidance. So we already talked about opening narrowed vessels, where previously you would have to have a surgical bypass. We can reline aneurysmal vessels. So if someone has a abdominal aortic aneurysm, those used to almost always be a big open surgery, and now they're almost always done with a stent graft, and all done through accessing the blood vessels in the groin and going up to the abdomen that way. You can place catheters for dialysis or other central venous access. You can put probes in that deposit heat energy and kill tumors without actually needing to open you up and cut it out. You can stop bleeding during a trauma if someone comes in and injures an artery in their leg and it's bleeding and they're dying from blood loss. You can stop that vessel from bleeding. You can dissolve clots that form in different areas like the pulmonary arteries or the brain to reverse a stroke. You can even deliver chemotherapy through the arteries directly into a tumor. And so instead of getting systemic chemotherapy that leads to a lot of toxic side effects in your whole body, you're delivering it locally just to the tumor itself to minimize side effects. So this is kind of a little older, and I'm not sure how well it's projecting because it's a very busy slide, but basically these are all different areas that interventional radiology can do things for. So from biliary disease, vascular malformations, venous disease, within that there's thromboembolic, varicose veins. You can, treat all different areas of the body that have veins. Urinary disease, so we work closely with urologists for dialysis patients with fistulas, for livers, for uterine fibroids for women, for aortic dissections. There's just a huge swath, and then cancer treatments as well, like I mentioned. So you need to really know a lot about a lot of different things, and that's why our training path is so long. So two things I thought would be kind of nice to talk to you all about are peripheral arterial disease and benign prostatic hypertrophy, or BPH, as it's called. So sorry for the gross pictures, but peripheral arterial disease is basically decreased blood flow, usually to the legs, but can happen in the arms as well, just less commonly due to plaque buildup. So this is similar to blockages in the heart, except it's the arteries going to your extremities. It's a large problem in the US. There's probably around 10 million Americans that are affected and over 200 million globally. It's increasing over time, and it's strongly correlated with increasing age, smoking, diabetes. Just in 2004, there was an estimate that $21 billion was spent for peripheral arterial disease. Symptoms of this are pain with walking or cramping, which is called claudication. There's continuous leg pain, which is rest pain. So that's worse. So if you're just sitting down or laying down at night and your legs are hurting because they're not getting enough blood flow, then that's a sign that something is not good. You can get skin changes, hair loss, and then finally, when it gets very severe, you can develop wounds and ulcers, and then those can get infected, and that can lead to a very dangerous situation. So like I said, it increases with age. You can see, you know, in their 40s, not many people are affected, but as we increase in age, especially in the 70s and 80s, it's affecting a very significant portion of that population. And so, like I said, this is a disease of the arteries. And a lot of patients with peripheral arterial disease also have disease in their coronary arteries and then the arteries leading to their brain. So it's associated with heart attacks and strokes. And that's why it's a pretty deadly illness, or can be, just because most people don't actually die from their peripheral arteries, but they'll have a lot of issues due to heart attacks or strokes. And it gets worse over time if it's untreated. So this was a study one of my faculty members at UVA did, just trying to estimate how many people at kind of in the UVA area. So the 11 counties surrounding Charlottesville that we get patients from, how many people have PAD. And he came up with around 13,000 patients. And when he looked at UVA, how many patients we were actually treating, it was in the hundreds, I think, under 1,000. So there's a lot of untreated disease out there. So screening for PAD, it's really cheap and easy. Basically, you can take blood pressure cuff readings at the ankle and then the arm, and then you divide those and you come up with a ratio. And if it's normal is 1, and if it's less than 1, especially less than 0.9, then it's starting to become abnormal. And then, like we talked about, there's a risk of cardiovascular events and then increased mortality with this. So the American Diabetes Association recommends screening any patient older than 50 who has diabetes, and the American Heart Association recommends screening patients who are 65 and older, or if you're 50 and older and have a history of diabetes or smoking. So just something to keep in mind if you haven't been screened for this before and those apply to you. Now, treatment for PAD depends basically on how severe it is. So for people with minimal symptoms or claudication, which is the cramping and pain with walking, usually you start with just conservative management. So, you know, losing weight, exercise, maximizing medications to reduce plaque buildup, stop smoking, things like that. Once it becomes lifestyle limiting, or if you're having rest pain or tissue loss, then that becomes a more urgent problem, and you should see either an interventional radiologist or a vascular surgeon to figure out how they can fix this. And the treatments are all kind of tailored to the individual. It depends where the disease is most severe. But the trend is towards minimally invasive treatments like the ones we do in IR. So I'd just go through a couple of cases just to show what this looks like. So these are pictures from an angiogram. So are you all able to see my mouse by any chance or no?
Yes, we can.
Okay, perfect. Sorry, I've just been waving it haphazardly throughout the presentation, but you can see this. So the dark areas here are contrasting the blood vessels. So we're seeing the blood vessels. This is the femur at the hip. This is the bottom of your pelvis. This is called the profunda artery. So that's feeding the thigh. And then this is called the superficial femoral artery. And it should be a big artery, kind of the size of this one, coming all the way down the screen and going towards the knee to feed the lower leg. And as you can see, it kind of peters out here and then disappears. And then down here towards the knee, lower in the leg, you see all these tortuous little thin vessels. So those are new blood vessels called collaterals that develop to get around that blockage to help feed the leg. But it's not as efficient as a normal artery. And that's why you, because of that decreased blood flow, you get pain when you walk, because it's increasing the demand for blood and oxygen, and it just can't carry it well enough. So what we've done here is access the other groin, put wires and catheters to get down across the pelvis and into the other leg. And then this is a special device called an atherectomy device that we can use. It's basically a little roto-rooter, and we can shave off the plaque inside the blood vessel to help remove the plaque, debulk it, and then after that, we can balloon it open, like we talked about with the angioplasty. That stretches the vessel open, pushes the plaque to the wall, and increases a space for blood flow. Here you can see afterwards, whereas on the prior slide, you can see, there's not one big artery coming down, it's all these little squiggly ones. Now you have this one big artery coming down. So it's and you don't see those collaterals as much. This is a very good looking result. And this person, if they had a wound, that wound will probably heal a lot faster now, or if they were having pain with walking, either that pain would be resolved or they would be able to walk a lot further before having that pain. Here's another example. So here we're at the level of the knee going down, and you can see instead of having, there should be 3 arteries here at this level, kind of all going down without all these little squiggly ones. And so there's a lot of collaterals here. All these 3 vessels kind of end around here. And then you can see there's very little blood flow to the foot. So this person has left foot ischemia. They probably have rest pain, or they may have ulcers on their feet. Here we've gotten down again with wire, balloons, catheters. We stretched the blood vessels open with these balloons. We've come up from the foot. So that's something especially IR is very good at, is working in very tiny blood vessels. A lot of times vascular surgeons can do some of this, but they aren't quite as adept at these very small vessels because they aren't trained as well as we are. So we get up there, we can balloon it open. Now you see big vessel coming down, good blood flow going through, and then we've restored blood flow through this one main vessel. So it's what we call inline flow. So now there's a continuous path of blood through normal vessel and at least one going to the foot. So that's good enough to heal things and will help with symptoms. This is someone that's had a stent placed, so you can see the metallic stent here. We do that when balloons aren't enough, but over time, kind of junk tends to build up in those and the blood flow gets less. So you can see this should be a solid kind of pipe of contrast. Instead, you have these little threads with narrowings. So they probably have symptoms. And so this is actually a laser that we can put in and kind of vaporize that plaque that builds up in the stent. And then here you can see what it should look like, this nice big vessel carrying blood. So switching gears, BPH, or benign prostatic hyperplasia, is something that affects a lot of men as they get older. Approximately half of men in their 50s have it, and then in their 70s and 80s, it can be as high as 80 or 90%. Your prostate gland grows throughout your entire life and just keeps growing. And when it gets big enough, it can either slow or stop urine from leaving the bladder and you being able to urinate, which is called bladder outflow or outlet obstruction. And if you have these symptoms, it's called lower urinary tract symptoms, or LUTS. This can include frequent urination, urgency to urinate, having to wake up in the middle of the night multiple times to urinate, having a poor, weak stream of urine, and being unable to completely empty the bladder. This is just a slide kind of going over some of that, but over 15 million men have BPH. There's 8 million visits to doctors annually, and over $3 billion is spent each year to treat BPH. You can start for mild symptoms with medication, which can work decently well, but once your prostate gets to a certain size, a lot of times the only options are more invasive than medication. And so traditionally it's been treated by surgery with a urologist, but those can have a lot of side effects, especially sexual side effects. So there's a decent risk of impotence or retrograde ejaculation. No one wants those. So we came up with a minimally invasive solution in IR. So it's called prostate artery embolization, but basically what you're doing is accessing either the groin or the wrist. You get a catheter into the artery in the pelvis that feeds the prostate gland, and then you inject a bunch of tiny little glass or plastic beads, and these block the blood flow to the prostate, which starves it of oxygen and then causes it to basically shrink over time. And this has been shown to be really effective, almost as effective as surgery, but with significantly less side effects. You can go home either later that day or the next day. And it's been done in over 2,000 patients with very good results. So here's just a little picture showing that. This is obviously not real, but you can see accessing the groin, basically catheter going through the other side, going into the artery, feeding to the little spheres. So things I'd like for you guys to take away from this is, you know, if you're older than 65 and you've never had that ankle brachial index performed, it's a good idea to just ask your primary care doctor about that, just because it's kind of something silent that may not affect you at first, but the earlier you can catch it and get treatment for it, the better off you'll be. If you're older than 50 and either are a smoker, were a smoker, or have diabetes and haven't been screened, you should ask about it. And then if you do have these symptoms that we talked about, cramping or pain when you walk after certain distances, pain in your legs when you're just laying down or resting or sleeping, or if you have ulcers or wounds on your feet especially, you know, if no one's seeing you for this, we'd be happy to see you at UVA Interventional Radiology and try and get help for you. If you're a male and you have symptoms of BPH, if you're being managed by a PCP or urologist, you can ask them about this procedure and ask to get a referral if it's something that needs more than medication. So that's pretty much it. Does anyone have any questions about anything or something I'd like to ask about interventional radiology?
So I'm going to allow you all to unmute yourselves, and if you have any questions, you can do that, or you can put them in the chat. I do have a plaque question, if that's okay. So I'm familiar with stents, and this is just fascinating. But when you use angioplasty or anything else like that, aside from the tool you all have to scrape out the plaque, when that blood vessel is opened up, does the plaque kind of move around, or does it want to go back to the shape it was in prior to the expansion?
So that's it's something we call recoil. So especially if you're not placing a stent, when you just do the balloon, you try and kind of overstretch it and then hope that inevitably it'll recoil, but you want it to recoil to at least better than it was before. And it depends on the plaques. Certain plaques respond better than others, but it's definitely an issue. And we have newer technologies now with certain drugs that can be coated on the balloon that actually soften the plaque and then help prevent it from growing back. So there's really cool things like that that we've come up with.
Amazing, thank you. I see Berta and Eleanor.
Yes, is there a place where we could get a copy of your presentation, the notes that you put up on the screen?
Sure, I can probably just send that to Carolyn, and I'm sure she can find a way to get it to you guys if you'd like.
Great.
Absolutely, just email me and I'll put my email in the chat.
Okay.
It looks like I got a question from Anne in the chat. Intervention part I understand, but where does the radiology aspect appear? So that's a good question. You know, radiology is just medical imaging, right? So all these things we're talking about are done with image guidance. So if you saw on in the video or some of those pictures, usually the patient's lying on a X-ray table, and then we have a X-ray machine that we're moving around and taking live X-rays as we're doing the procedure. So we're seeing everything in real time. We can see exactly what we're doing. And interventional radiologists are all also diagnostic radiologists. So my training pathway is 6 years. I did a year of surgery as an intern year. Then I did 4 years, or kind of 3.5 years of diagnostic radiology. You get board certified in diagnostic radiology, and then you do a fellowship in interventional radiology, which is anywhere from a year to 2 years, depending. But you do some of that throughout, so it's all kind of mixed together. But that's one big advantage of interventional radiologists is we're able to really understand the physics and the imaging and what things should and should not look like. And so we're kind of masters of imaging and then how to use imaging to actually treat things.
Will you be able to deliver medicine, chemotherapy, anything through this method, say for treating cancers?
Yeah, that's a great question. And so, yes, that's something that we do routinely for certain types of cancer. So one of the biggest areas that we do this is for liver cancer, hepatocellular carcinoma, which usually affects people with cirrhosis or liver failure, but can happen in patients with healthy livers rarely. But we can go in usually through the groin, go into the aorta, which is the main artery that feeds the body coming off the heart, and then using these catheters and wires, select the arteries that go to the liver, and then select the artery that feeds the individual tumor. And then there's a couple of things we can do at that point. You can either use beads just to block the blood flow. You can use beads that are coated in chemotherapy. So that's basically poison that's meant to treat the tumor. And the great thing about that is you can use a higher concentration that's more lethal to the tumor. But because it's going directly to the tumor and not throughout your whole body, you don't have the systemic side effects of diarrhea from it poisoning your gut. You don't lose your hair, all that stuff. And then now actually what we can do is use special radiation beads that use a radiation that's very potent but only goes a short distance. So we implant the radiation beads directly into the tumor through those arteries, and then the radiation goes on for a while and just kills the tumor around it. And so we can do that for liver tumors. We can do that for colon tumors that have metastasized or migrated to the liver. And then we do it occasionally in other parts of the body, but it's mostly in the liver now. But like I said, this is a young field, and they're constantly coming up with new things. So
are they looking at prostate cancer at all for this?
So they may be doing kind of animal trials. I haven't heard of that it's certainly not approved yet for humans, but that's a very good thought. And I think it's something people are working on. It just takes time. You have to show that it works. Certain tumors respond differently to certain things. But that's a great thought.
Good, thank you.
I see Tom Cross has a question.
So Tom asked, does any of this relate to erectile dysfunction? So erectile dysfunction, I think can be caused by BPH, can affect it, but often there's a lot of things that can cause erectile dysfunction. So just BPH, because it's so common, it may or may not be related, but the treatment for BPH surgically can have a high risk of causing erectile dysfunction. And so that's one thing that pushes a lot of people to trying to get this procedure, the prostate artery embolization, because it's much less invasive and there's much less risk of those sexual side effects. And it's something that a lot of patients don't get told about, because urologists, they're great, it's their specialty, but they they want to do the surgeries. And so often they don't refer patients to us, even if it may be a better option in a lot of cases. So that's why just knowing about it, knowing about options, and talking to your doctor about it is really important. Vicky asked about removing plaque that was pushed aside by the balloon or stent. So yes, that's definitely something we do, and that's what I was referring to with that atherectomy device. So atheroma is a word for plaque. It's like a fancy medical word, and then atherectomy just means removing plaque. So we can use things that shave off the plaque. There's ones that it's basically a little drill bit that spins extremely fast, like 35,000 times a second, and it kind of pulverizes the plaque, especially heavily calcified ones. And then there's ones that use laser beams to heat and kind of vaporize plaque. So there's a fair amount of different choices for that.
Do the patients going into the surgery know which one of these techniques that you might be using to get rid of the plaque?
Sometimes we don't know beforehand what we use because certain devices work better for certain things based on how they look, and we won't know how they look until we start the procedure. But usually we'll go through kind of all the options of what we think we may end up using and just tell the patient about them. You know, each thing has its own different risks and benefits. So we go through all that before the procedure and make sure that they're comfortable with whatever we're doing. Tom asked if interventional cardiologists get the same training. So they get sort of some similar training, but so I talked about my training path, which is 6 years. You know, 5 of those years are directly related to imaging, radiology, image-guided procedures. For an interventional cardiologist, they do 3 years of general medicine, where they do almost no procedures. They do 3 years of cardiology specialty training, where they may do a little bit of cardiac cath for procedures, but mainly they're just learning the medical management of heart disease. And then they do a subspecialty fellowship, which is interventional cardiology, which is usually a year, I think, on top of that, maybe. I can't remember if it's more, but they do a lot in that year, but it's just not the same amount of time over the course of their training as an interventional radiologist. So I don't do anything in the heart because you know, I haven't been trained for it. There's interventional cardiologists that are really good, and there's certainly excellent ones out there. Some of them do treat peripheral arterial disease, but I think on average, just because of the differences in training, I would see an interventional radiologist before an interventional cardiologist for something outside of the heart, just because they really focus on the heart, and there's differences when you're doing stuff outside of the heart. And likewise, I wouldn't see one of my colleagues about something in the heart because I'd rather see an interventional cardiologist for that.
And how would somebody who's seeing their doctor and have one of these problems know to even ask about somebody in your specialty?
Yeah, so unless you know, now you're in that position because you've heard this talk, so that's one way, is just kind of community outreach. But it's really hard as you know, a lay person outside of medicine to know how medicine works, how the different fields interact, and even within medicine, you know, I've been involved in it for almost 10 years now, and there's still a lot of things you won't know, and you have to talk to people about. So it's really hard to be kind of an educated consumer. I think, you know, just asking a lot of questions, always just having a firm understanding of what's going on. And then, you know, you can always ask for a second opinion. No physician is going to be offended. That's a normal thing. You know, if you're perfectly happy and everything they're saying is making sense, you know, you don't need to. But if something doesn't sound right, or you just want to hear about other options, it's good to ask about things like that. So that's one way. But it's tough because, you know, a lot of primary care doctors don't really have much exposure to interventional radiology. So, you know, how can they tell you about something if they don't even understand it themselves? So it's a lot of education that has to happen both within medicine and then to the public as well.
A couple of questions in the chat there. Vicki, are they looking at breast cancer for this?
So for breast cancer, I haven't seen anything for that. Breast cancer is one of those things where I'm sure in the future there will be something like that. For benign tumors like fibroadenomas, they're using focused ultrasound to help shrink those or kill those non-cancerous tumors using heat energy from special ultrasound equipment that doesn't use radiation. So that's something that's in the works, and at some point maybe they'll try and do that for breast cancer. But because the breasts are so superficial and they're very safe to operate on because there's not, you know, much else that's really important there. It's a pretty benign surgery, and it's a pretty quick and safe procedure when they remove breast cancer. But I'm sure at some point in the future there'll be something for that, just not currently. Does this have anything to do with numbness in the pad of your feet with type 2 diabetes? So the numbness in your feet is because of the diabetes. So diabetes affects the very small vessels. It shuts them down, and then this causes nerve damage. And so the nerve damage is what causes that numbness that you can get with diabetes. And so numbness can be a sign of peripheral arterial disease, but in the setting of diabetes, usually it's more so pain that we associate with peripheral arterial disease, and numbness is more associated with the diabetes. But if you have diabetes, you know, making sure you're working with your physician to get your blood glucose under control, get your diabetes under control is really important because, you know, it can get worse. And usually if you already have numbness or tingling or sensation loss, you won't get that back, but at least you can stop it from getting worse over time. So once plaque is removed, is it flushed through the system? How is it physically removed? So that's a great question. So when we take out the plaque, we do a couple of things. I didn't talk about it, but you put in a what we call a distal embolic protection device. So it's basically a little waste basket, but you know, very tiny, just a few millimeters. And we go past where we're shaving the plaque off or removing it. That's there as a safety to catch anything that the device itself doesn't catch, because what we don't want is in someone that has peripheral arterial disease, just send a plaque down to the further in the leg and block off blood flow with that. So that helps catch anything, and then we remove that to really carefully to make sure we don't spill anything. And because you know, we always want to make the patient better with our procedure, and the worst thing you can do is, you know, take someone that was doing okay but had some issues and then, you know, make the situation a lot worse. So we work really carefully to make sure that doesn't happen. But that's a great question. Do you repair aortic aneurysms? How does what you do for that differ from Dr. John Kern's research in that area? That's a great question. So we definitely do aortic aneurysm repairs. We actually work very closely with John Kern. He just had a big case for an aneurysm yesterday that we did with him. But he's an incredible surgeon. But we work together because he is incredible, but he specializes more so in open surgery, whereas we specialize in these minimally invasive techniques. So what we'll do a lot of times with him or some of the other vascular surgery colleagues is we'll work together to come up with a plan. You know, what would be best for the patient. We'll both be in the operating room together and help them with deploying these stent grafts and stuff. So it's not like that everywhere. And, you know, sometimes the vascular surgeons do this on their own as they become more proficient with it, but it's definitely something that interventional radiologists help kind of advance as a field, and we're certainly happy to help with. Any other questions from anyone?
Just a comment.
Uh-huh.
Dr. Norby, I contacted a couple of years ago. I knew him when he was a volunteer, at the center, and I contacted him because after a car accident, I'd had a filter put in my major artery, which had to come out. And it was going to be coming out through IR. And the procedure was extraordinary. And I contacted Dr. Norby for his advice. And then I was amazed. I was in and out in a number of hours, not even half a day, and recovered perfectly well. And it was through the jugular, which scared me to death, but not really. I did not die. It was extraordinarily successful. And I would certainly recommend anybody going through the process with IR if it's at all possible.
Thank you for that, Berta. We're happy to help take care of you, or anyone here. Like you said, it's pretty amazing what we can do now compared to in the past. And a lot of these procedures are outpatient. You come in the morning, you'll get medications through an IV to kind of make you a little sleepy and relaxed. And then usually the worst part is just the numbing medication that we use. It may burn a little bit, but after that, hopefully you don't feel any pain. Procedures can take anywhere from a half hour to a few hours, depending on what it is. And then you just recover from the sedation in our recovery area. And then a lot of times you go home, just after a few hours, or sometimes you have to spend the night, but it's pretty rare for someone to spend more than one night in the hospital after they've had a procedure with us, unless it's for something unrelated to our procedure. So, it's really changed the way medicine is done. And we honestly have an incredible team here at UVA, not just the physicians, but our nursing staff, our technologists who help us with the imaging. The whole team is, UVA has a great system, but within that, I think our IR team is probably one of the best, if not the best, in the entire hospital. So I'm really lucky and privileged to work with such great people. So if you ever need anything, definitely feel free to reach out. Carolyn can give you all my contact information. If you have any questions about anything, I'm happy to answer them. I'm very busy, so hopefully if I don't respond to you immediately, don't take offense, but I'll get back to you eventually.
I have another question. If you're experiencing numbness or pain in different parts of the body and you feel it may be some blockage in the veins or the arteries, would it be appropriate to approach someone like you, an IR person, rather than going to some other specialty to have it evaluated?
So it kind of depends. If you've never, if you're having pain somewhere, there are a lot of things that can cause pain, right? So, it could be arthritis, it could be something else, it could be your arteries. It's hard to tell. And so a lot of times it's best to start with your primary care doctor, just because they should be familiar with all of this. They can kind of, figure out kind of which bucket you're in terms of, what makes it better, what makes it worse, and kind of go from there. And then at that point, if you do need to see a specialist, then if it is something with the arteries, I think talking to an interventional radiologist is totally appropriate and a great thing. We can definitely help treat that. A lot of times, just because it's not as well known, vascular surgeons end up being the ones that are contacted. And we have great vascular surgeons here at UVA, but they aren't quite as facile, I think, with this endovascular techniques and minimally invasive. They're still great, but that's who I would send my family to, is if there was a problem with the arteries, it's to IR.
Okay, thank you.
Tom, I saw at a, let's see. Yeah, that's awesome that you worked with Dr. Kern. I've worked with him before. I know he's a great surgeon. If you have an aneurysm, I would definitely talk to Dr. Kern about it, since you have a relationship with him already. If he, aneurysms, it depends how big it is, how how much it's expanding, kind of what your anatomy looks like on imaging, on what the best approach is for treating those, if it needs to be treated. Some of them, you know, we can watch and just keep an eye on. So just definitely talk to Dr. Kern about that, just because you've worked with him before. But you know, if you say you'd be interested in hearing what interventional radiology can do, we have a very good relationship with him, and I'm sure he'd be happy to involve us or refer you to us if you thought you needed it. And thank you for the kind comments. I really appreciate it, and hope you guys all took something away from this, or wasn't just me blathering on for a little bit with nothing.
No, not at all. I mean, one of the things that I so value about Berta bringing on all these wonderful physicians is getting a deeper understanding, so you can ask intelligent questions when you're having, you know, potentially very life-threatening or scary things happen to you. It must make the doctor's job a whole lot easier too, to have someone come in with a little bit more knowledge, because you are busy. So I appreciate the education, and I know we all do here as well. So just one quick question about UVA or interventional radiology there. How do studies, how do you, you know, compare and contrast, say, Dr. Kern's work with yours, and which one might be more effective with what kind of disease or illness? I mean, how does that get logged?
yeah, it's tricky. You know, it's kind of like a spider web of, you know, referral patterns, and which physician your doctor likes and who they want to send them to, because there's multiple people a lot of times that can manage different things. But you know, ultimately, if you're working with a good doctor, you know, they're gonna keep your best interests in mind, and you know, work to the best of their ability to do what they think is best for you. And if that involves sending you to someone else, hopefully they'll do that. If it's something they're able to treat, and you know, they know they can do a good job and it's safe for you, then they'll do that. But yeah, I think, like I said earlier, just advocating for yourself, asking a lot of questions. You know, there's a lot of resources online. There's a lot of scary stuff you can read that is very questionable. So I think just if you have someone that you know in the medical field, reaching out to them. But you know, I think the best and most important thing is probably just finding a primary care doctor that you respect, and you know, that they respect you, and just asking them about stuff. If they don't know it, you know, they're a physician, they can take the time to learn about it and come back to you or get back to you. So they can also educate themselves. But that, I think, is your most valuable resource, is having a good primary care doctor that knows what they can do, and then knows where to send you when you do have a problem that requires kind of a higher level of care.